Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
This program is presented by Medscape Education Global.
Hello to everyone. I'm Paolo Ghia. I'm professor of medical oncology at Università Vita Salute San Raffaele Milano, where I'm also directing the strategic research program on chronic lymphocytic leukemia. And today I welcome you to this educational event, which is actually an expert discussion of key new data in chronic lymphocytic leukemia and mantle cell lymphoma. How may it impact future practice? And I'm joined by Kemi Maddox, professor of clinical internal medicine at Ohio State University, Columbus, Ohio. Welcome, Kami. And in this activity, Kami and I will present the most important and interesting clinical data from the past year on chronic lymphocytic leukemia and mantle cell lymphoma. And we will also discuss what these findings mean for clinical practice. And I will be starting talking about the chronic lymphocytic leukemia, CLL, with a number of abstracts that have been presented at the different international congresses during the past 12 months. And in particular, I start with the final analysis of the phase 3 Gaia CLL 13 trial, which is a study by the German CLL study group, actually international study with many other countries involved. And this is a peculiar, interesting, very interesting study because it compared the 3 different time-limited venetoclax-based combination against the chemoimmunotherapy, being this FCR, fludarabine cyclophosphamide and then rituximab, or BR, bendamustine rituximab. And the venetoclax-based combination were either venetoclax plus rituximab, venetoclax plus obinutuzumab, or venetoclax plus ibrutinib plus obinutuzumab in frontline patient with CLL. And we already saw the results a number of times. This was the final analysis that showed finally that there is an advantage in terms of progression-free survival for the triplet, ibrutinib, venetoclax, obinutuzumab. There is also an advantage of the triplet versus the doublet, so the ibrutinib, venetoclax, obinutuzumab versus venetoclax plus obinutuzumab. But we have also to keep in mind that the safety profile of this combination, and indeed the triplet also turned out to be the one that was less well tolerated, with a higher frequency of infections, higher frequency of cardiac disorders, probably due to the combination with the BTK inhibitors, ibrutinib, and also an increase in second malignancies. So by keeping this in mind, we have probably to balance all the different factors in order to decide in our clinical practice what is best for our patient, either the combination of obinutuzumab plus venetoclax, or if we want to look for higher efficacy, and we are also able to, let's say, to use it, for example, in younger patients with less safety issues, maybe we can consider the use of the triplet ibrutinib, venetoclax, and obinutuzumab. Another important study that has been presented in the past 12 months is also the final analysis of the Captivate study. The Captivate study was and is a phase 2 study that investigated for the first time the combination of ibrutinib, the BTK inhibitor, and venetoclax, the BCL2 inhibitor, in a young fit population up to 70 years of age in a fixed duration, which is indeed the scheme that is now approved in Europe and many other countries. So 3 cycles of ibrutinib followed by the 12 cycles, 12 months of combination of ibrutinib plus venetoclax. Everybody stopped and as a time limit treatment and then followed up. Now we have a long-term follow-up, where we have been able to show the 5.5 year, 5.5 year progression-free survival rate was which remained um, unreached, meaning that 66% of GA patients, so two-thirds of the patients, were still free of progression, with 97% of patients still alive. So these are very interesting um, and remarkable data, in particular thinking that the patients were treated only for 15 months. And of course, we do see a shorter PFS in patients with unmutated immunoglobulin genes, but still remains 59% of patients who are free of progression after 5.5 years, even if they carry unmutated immunoglobulin genes. Different argument for patients with p53 aberration on deletion 17p, where only 30% of patients will remain without progression after 5.5 years. But it is also remarkable that with only 15 months, still one-third of patients almost with deletion 17p or p53 mutation were free of progression after so many years. So this is something that we have to keep in mind. Of course, these important results were obtained because the combination was able to achieve undetectable MRD, minimal residual disease, in a large proportion of patients, 60% of patients at the end of treatment. And the value of undetectable MRD at the end of treatment really strongly correlated, was a strong predictor for long-term progression-free survival, including the patient with deletion 17p, NP, and or p53 mutations. So this is something that maybe in the future we have to keep in mind, and maybe we have to personalize the treatment based on MRD in particular in this category of patients. The final analysis was also important because it showed the possibility of retreatment of patient after progressing after terminating ibrutinib plus venetoclax, and the patient had been retreated with either ibrutinib alone or ibrutinib plus venetoclax. In the case of monotherapy ibrutinib, we had a PFS of 91%, a 2 years PFS of 91%, and for a patient who had been retreated with ibrutinib plus venetoclax, the follow-up is shorter, and it's only 1 year PFS, where it's still 100%, but really indicating the possibility that indeed after a time-limited treatment, we can retreat the patient with the same drugs and obtain a very similar efficacy. No resistant mutation in both BTK or in either BTK or PLC gamma 2 or BCL2 have been found, again underscoring the value of time-limited treatment, which does not allow clonal revolution to occur. I mentioned about undetectable MRD. There was a study, the FLAIR study, that was built around MRD detection, and this is also it's been presented, and the FLAIR study compared fludarabine cyclophosphamide and rituximab SCR to continuous ibrutinib, but in particular to ibrutinib plus venetoclax given in an MRD-driven fashion. In particular, the design of the colleagues from Britain, UK, was that the patients were treated with I plus V for a time that was double the time they needed to achieve undetectable MRD. So if the patient needed 2 years, he was treated for another 2 years. If he needed 3 years, he was treated for another 3 years. The maximum allowed being 6 years in the trial. And the data that have been presented were really significant because it showed for the first time an advantage in the MRD-driven I plus V combination compared to continuous treatment with ibrutinib, but that has been always considered to be the gold standard in terms of efficacy, long-term efficacy in CLL. Of course, the combination I plus V was also superior to immunochemotherapy, to FCR, and it was superior in terms of PFS and overall survival when we consider patients with unmutated immunoglobulin genes, and in terms of PFS when we consider patients with mutated immunoglobulin genes. The patient could stop the treatment based on achievement of undetectable MRD, and roughly 3/4 of patients, 73.1% of patients, indeed stop the treatment due to the MRD stopping rules by 60 months. So we have to consider that anyhow, many patients have been treated for at least more than 2 years, if not up to 5 years, and still a quarter of the patient did not yet stop the treatment. In terms of safety, the combination, the single therapy and FER are well known, and there have been no new flag in terms of safety. Definitely the I plus D combination in an MRD-driven setting resulted in a lower number of deaths compared to SCR, but also to ibrutinib. Now from the front line, I switched to the relapsed refractory setting with another important study, the phase 3 Bruin CLL 321 trial. It's a phase 3 study in the relapsed refractory setting of patients with chronic lymphocytic leukemia, where pirtobrutinib, a third generation BTK inhibitor, was compared to a physician choice of idelalisib plus rituximab or bendamustine plus rituximab. And the important milestone of this study was that for the first time, the study enrolled only patients who had been exposed previously to a covalent BTK inhibitor. And that's the first study in this particular setting, which we know is a difficult setting of patients to be treated. The median progression-free survival was better for pirtobrutinib compared to the physician choice, in particular 14 months in the pirtobrutinib group. But what is most important is the time to next treatment, 24 months with pirtobrutinib, which is relevant because, again, as a BTK inhibitor, pirtobrutinib was given continuously until progression. So until progression, but in particular until the need of the subsequent therapy. So even if the patient started progressing, they were maintained on therapy until they had the clinical benefit. And therefore, that turned out to be a time to next treatment of 24 months for this patient. The adverse events were lower pirtobrutinib, and again were rather what we expected, what we already were aware from the phase 1 study. So in particular, bleeding, very low frequency of atrial fibrillation, and the cardiac disorders. We also presented the patient-reported outcome that again underscored the efficacy and the benefit, the clinical benefit the patient obtained, and in fact, patient treated with pirtobrutinib showed improvements in CLL-related symptoms in general, in their physical function, and also in terms of fatigue. Again, in the relapsed refractory setting, we are now opening a new path with the BTK degrader. It's a new drug, a new drug type and a new drug group. The BTK degrader, they degrade BTK. They are not only blocking it, they are really destroying it through the proteasome pathways. And this has been tested in the Cadence 101 study for relapsed refractory patient with chronic lymphocytic leukemia. And the vast majority of these patients, 94%, were already exposed to covalent BTKI, but also more than 80% to BCL2 inhibitors. And the drug has been very well tolerated with a safety profile that was very similar to BTK inhibitors in general. So you may expect contusions, you may expect neutropenia and infection, but that's also expected somehow in the relapsed refractory setting. In terms of efficacy, different dose has been tested. In the 200 milligram dose group, overall response was above 90%, 93.6%. And even in the patients who were triple exposed, so BTK, covalent BTK inhibitor, BCL2 inhibitors, and non-covalent BTK inhibitor, 3/4 of the patients, 75% of the patients responded. PFS at the moment still a short follow-up, 12 months, but 3/4 of the patients, 77.4%, are still responding. Of course, now there is an entire new development pathway in front of this drug, and it's going to be evaluated in phase 2, but in particular in phase 3 studies. And then I close with a combination of a new BCL2 inhibitor. We still have only one single BTK inhibitor, BCL2 inhibitor, which is venetoclax. Now we have also sonrotoclax that is tested in combination with zanubrutinib, a second generation BTK inhibitor in the relapsed refractory setting. And again, the combination is very well tolerated. As we might expect, we have now a lot of experience with the combination of BTK and BCL2 inhibitors. In particular, we have to keep always an eye on neutropenia, but it's very impressive in terms of responses. Overall response was 96% in the entire cohort. For the 320 milligram cohort, the overall response was 100%. And if we look at also the MRD, undetected MRD, um, it was very deep. The frequency of undetectable MRD was very high, reaching already 80% of the patient after 48 weeks. And for those few who achieved 96 weeks of treatment, 100% of patients achieved undetectable MRD at the level of 10 to the minus 4 with the 320 milligram dose. So, and there is also a future for this combination, in particular also for these BCL2 inhibitors that is now promising, showing a 13-month progression-free survival that is 94.7%.
Thank you for that great overview of those abstracts, rapid and great overview of those abstracts. In general, just some thoughts on the implications of these data. Are there things that are immediately practice changing? How are you approaching these BTK BCL2 combinations in patients now, and what do you think is up for future?
Yes, indeed. As I tried already to allude to, I think that the future in frontline is for doublets, definitely for time-limited treatment. And the last arrays of studies, it's really confirming, underscoring the efficacy of this treatment, being that venetoclax plus obinutuzumab or ibrutinib plus venetoclax, those are very effective with a short period of time. The triplet, probably there is a little bit less enthusiasm now, because every time we look at the triplet, the addition of anti-CD20 antibody to BTK and BCL2 inhibitor, we always see an increase in terms of adverse events. So it make us always very cautious in selecting the right population where we could use the triplet. MRD is here probably to stay. Again, also in the Captivate study, patient with deletion 17p and p53 mutation who achieved undetectable MRD had the best PFS. So maybe we have to aim, in particular in that subgroup of patients, we have to aim for undetectable MRD. The FLAIR study, of course, confirmed that if you achieve that, you have a better progression-free survival. Probably if not a one-size-fits-all approach, but we have really to keep in mind that maybe it will become part of our armamentarium in the clinical practice. For relapsed refractory setting, pirtobrutinib is again here to stay, is something very concrete. We know that it works and it's definitely very useful to salvage our patients, either immediately after failing covalent BTKI or after failing also the BCL2 inhibitor. The BTK degraders are really probably the future, are showing very effective, a high grade of efficacy in the relapsed refractory setting with patients with multiple lines of treatment who have been exposed to the best drugs that we have available, and still patients respond with numbers that approach 100%. So there is really a future, and hopefully they will become available in the clinical practice soon.
Great. Thank you again. I think now we'll move on to mantle cell lymphoma, where we have an additional 6 abstracts to discuss. So the first I want to highlight is results of this subgroup analysis from the ECHO study. So as a reminder, the ECHO study was a randomized phase 3 trial that looked at the addition of the BTK inhibitor acalabrutinib to standard chemoimmunotherapy with bendamustine and rituximab maintenance in patients with newly diagnosed mantle cell lymphoma who were older or not considered candidates for autologous stem cell transplant. This has previously been presented with the results of the entire trial, which showed an improvement in the primary endpoint of progression-free survival when acalabrutinib was added to bendamustine and rituximab. So more recently, we've seen an update that's showing us outcomes in patients with high risk disease. And this was defined by patients that had high risk MIPI, patients who had a high Ki-67 with Ki index of 30% or greater, patients who harbored TP53 mutations, and then patients with blastoid or pleomorphic histology. So looking at the efficacy in this trial, the overall response rate was higher with the addition of acalabrutinib, although this was about a 5% difference. However, we did see a quite significant difference in the complete response rate with the addition of acalabrutinib to the BR, with a CR rate increasing by 20% from almost 50 in the standard arm to almost 70% in with the addition of acalabrutinib. Looking at those patients who had high-risk disease by the biological factors, including TP53 mutations, high Ki-67, and blastoid or pleomorphic histology, the progression-free survival was significantly longer in these patients with the addition of acalabrutinib. So I think, we've seen in frontline mantle cell that the addition of BTK inhibitors to different regimens, both chemoimmunotherapy and non-chemo immunotherapy, has benefited patients. And I think specifically in these high-risk MCL patients that it's nice to have the option of including acalabrutinib in the frontline setting or other BTK inhibitors in the frontline setting to improve outcomes in these patients who do have inferior outcomes with standard treatment. I think the real question, is if bendamustine is going to end up being the best partner in these combinations. And that brings us to the next abstract that I want to highlight, and that is results from the Simpatico study. So as the last abstract, the Simpatico study has also previously been presented. And as a reminder, this was largely a randomized phase 3 study. It had 3 different cohorts, though. So the large part of the study was a randomized trial in relapsed refractory mantle cell lymphoma, looking at the treatment with ibrutinib versus ibrutinib plus the addition of the BCL2 inhibitor venetoclax. But there was also a safety run-in and then a single-arm cohort that allowed previously untreated patients and treated patients who were either older, 65 and older, or who had TP53 mutations, again, who do work with standard chemoimmunotherapy, with the combination of ibrutinib and venetoclax for 2 years, and then they continued on single agent BTK inhibitor with ibrutinib until progression. So looking at the results of this trial, high overall responses, but really very high CR rates in these patients who were older or harbored TP53 mutations with a combination of ibrutinib and venetoclax. Um, the the remissions were durable. If you looked at patients with the TP53 mutations, PFS was approaching 2 years. And if you looked at patients without the TP53 mutation, PFS of a little over 40 months. The safety profile was what would be expected with this combination. It did look like in younger patients, there trended to be improved safety profile. So this showed benefit to this doublet combination in patients who were older or harbored TP53 mutations for frontline treatment. I think when you look at this and other data we've seen, certainly in these patients with TP53 mutations, some sort of frontline treatment that utilizes BTK and BCL2 combinations in a non-chemotherapeutic approach is certainly of high interest. Moving on to a very exciting abstract that we saw, and this looked at the combination of the CD20 bispecific mosunetuzumab with the CD79B antibody drug conjugate polatuzumab. This looked at patients with relapsed refractory mantle cell lymphoma, all who had received prior BTK inhibitor therapy. So this combination was given, polatuzumab was given for 6 cycles, and mosunetuzumab was given for up to 17 cycles. And this was given as an outpatient regimen. Very impressive overall response rate. So overall response rates approaching 90%, with complete response rates occurring in the majority of those patients, almost 80%, with median duration of response and median duration of complete response not reached. I think what was specifically impressive about this combination was the high risk patient population. Again, all these patients had received prior BTK inhibitor therapy, and there was a high number of patients who had very high risk disease features, and the overall responses and complete responses were consistent across these high risk subgroups. So, patients who had high Ki67, actually greater than 50%, patients with blastoid or pleomorphic variant, patient with TP53 mutations, and even patients who had previously received CAR T cell therapy. Looking at safety of this, most common toxicities, fatigue, injection site reaction, neutropenia, and diarrhea. When you look at CRS, there was actually all CRS was grade 1 to 2. So there was no grade 3 or higher CRS. Um, 2/3 of the cases of CRS were grade 1, with 1/3 being grade 2, and a total percentage of 43%. This all occurred within the first cycle. So again, promising data in relapsed refractory mantle cell lymphoma, including high-risk patient populations, and CRS was low grade and manageable. The next I'd like to highlight is the phase 2 Valor study, and this is a frontline study. So this has also been previously presented. We saw results of this combination in the untreated mantle cell lymphoma that looked at rituximab in combination with venetoclax and lenalidomide, showing high overall response rates, complete response rates, and high rate of MRD undetectable disease. So what we recently saw was updated results of this. So 5-year follow-up of this triplet non-chemo combination in the frontline setting, in suggesting that the responses in these patients were actually very durable. So 5-year PFS of 70%, 5-year overall survival of 75%, with median duration of response, PFS, and OS not reached. This did include patients with high risk disease. So, this was active in patients with certain high risk disease features, including those with blastoid or pleomorphic disease, high risk MIPI, and patients who had high Ki67. But notably, patients with TP53 mutations did not do well with this combination. And all 4 of the relapses were in patients who had TP53 mutations. Most common toxicities, neutropenia, diarrhea, fatigue. Most common grade 3 or higher toxicity was cytopenias. This was could be hard on the counts. And there were secondary malignancies diagnosed in 5 patients. Now, this trial is being expanded with a larger patient population, but they have adjusted the time patients are on treatment to address the toxicities, and they are excluding patients with TP53 mutations, given that they seem to have short durations of response with this. Interesting combination in relapse refractory disease came out of the Goldilocks study. So this was a small trial, but it looked at the combination of the CD20 bispecific glofitamab plus a non-covalent BTK inhibitor pirtobrutinib. So both of these agents have been shown to have the activity in patients with mantle cell lymphoma who progress after covalent BTKI. Pirtobrutinib has an approval in this setting, and glofitamab is currently in a randomized phase 3 trial. So small trial, again, only 16 patients, but all patients had received prior covalent BTK. This trial did look at 3 different dosing cohorts. In the first dosing cohort, there was 2 dose limiting toxicities, and therefore they did a amp up of the steroid prophylaxis, enhanced the steroid prophylaxis for the cycle or the cohort 2 and cohort 3 dosing, and have not had the same safety issues with that enhanced steroid prophylaxis. So again, small number of patients, but overall response approaching 80% in the 13 evaluable patients, all of those achieving MRD undetectable disease. So more to come from this combination of therapy. And then the last abstract that I'll highlight is a phase 1 study. This looks at the newer BCL2 inhibitor, sonrotoclax, plus the BTK inhibitor zanubrutinib in relapsed refractory mantle cell lymphoma. So as mentioned by Paulo, sonrotoclax is a next generation BCL2 inhibitor. This was a trial in 51 patients with relapsed refractory mantle cell lymphoma. Uh, Phase 1 trial, most common toxicities, diarrhea, neutropenia, contusion. There was no atrial fibrillation or flutter, and no tumor lysis seen in this combination. Overall, this was demonstrated a high overall response rate, high complete response rate, so close to 80% overall response rate, with 2/3 of patients achieving a complete response. At the recommended phase 2 dosing, overall response rate was also near 80% at 78%, with 70% of patients having a complete response. 24-month duration of response, 84% in the entire population and 80% in the cohort moving forward. So based on this promising data, this combination is being evaluated in a phase 3 study. The Celestial Relapse Refractory MCL study is currently enrolling patients and randomizing them to single agent BTK with zanubrutinib versus the combination of zanubrutinib and sonrotoclax.
Thank you very much, Cami, and it has been really nice overview. And there is also a lot of new developments in the case of mantle cell lymphoma. Uh, I want to ask you exactly the same question, but maybe a little bit more specific on a particular curiosity, meaning that what are the implications of these data, in particular for the high risk patient? Because unfortunately, when we use only chemo-free treatment, I didn't see much of enthusiasm, let's say. Well, instead, probably the echo is the only one, the only scheme still including chemotherapy that can be effective. Would you use it in high risk patients, regardless of age? What is your patience for that scheme?
So I think it depends a little bit. Obviously, we didn't cover all the data. So I think in patients with TP53 mutations specifically, we've seen the simpatico data, but we've also seen the Bovin data, which looks at a triplet non-chemo combination just in TP53 patients. And that has shown the best data really in TP53 dedicated patients for in terms of outcomes, in terms of both like complete response, overall response, MRD negative, and progression-free survival, although that was small number of patients. So I think in those patients particularly, it's ideal to eliminate chemotherapy. Obviously, the triplet combination with the venetoclax and R squared was not good for that patient population. In other patients with high risk disease, I do think I have incorporated this. So, higher Ki-67, um, incorporated the acalabrutinib with the BR regimen. Of course, that was approved in frontline mantle cell in this patient population back in January of this year. I think, long term, the struggle always is if it's a patient that you think is not gonna have a long response to that kind of regimen and you're thinking that CAR T may be in their future, is bendamustine something you really wanna use if you're thinking that, if you're giving BTK in the frontline therapy and they're gonna have not a complete response or a short response and they can move on to one of the CAR products, is that the ideal combination? So I think we I think there's still more to come with the triplet combinations that we didn't talk about. Um, there's another trial, the Traverse study, looking at acalabrutinib, venetoclax, rituximab in the frontline setting. Oasis looks at the obinutuzumab with BTK and BCL2, and then the bovin, that's zanubrutinib, obinutuzumab, and venetoclax has actually increased their number of patient population. So, but for the time, yes, I have incorporated this into certain patients still using the non-chemo and the TP53 mutated.
Okay. Thank you very much. And I think that with this, we can thank all our audience, and we hope you enjoyed our discussion.
Thank you.
This program was presented by Medscape Education Global.